Welcome to Quick Medical Review, the podcast where we make complex medical topics simple, high yield, and exam ready. Today we're covering Tetralogy of Fallot, the most common cyanotic congenital heart defect, and a classic pediatrics and cardiology exam topic across USMLE, MRCP, PLAB, and SMLE. Let's get into it. Tetralogy of Fallot, or TOF, consists of 4 anatomical defects resulting from a single embryological abnormality: anterior and superior deviation of the infundibular septum. The 4 components are 1 ventricular septal defect, or VSD, 2 right ventricular outflow tract obstruction, which is the key determinant of severity, 3 overriding aorta, the aorta sits over the VSD receiving blood from both ventricles, and 4 right ventricular hypertrophy secondary to the increased pressure from the outflow obstruction. The degree of right ventricular outflow obstruction determines the clinical severity. Mild obstruction may allow adequate pulmonary blood flow and minimal cyanosis. Severe obstruction forces deoxygenated blood through the VSD into the aorta, causing significant cyanosis. Presentation depends on severity. Severely affected neonates present with cyanosis at birth. Milder cases may present later in infancy with progressive cyanosis, feeding difficulties, or poor growth. A key feature is TET spells or hypercyanotic episodes. These are acute episodes of worsening cyanosis, irritability, and potentially syncope, typically triggered by crying, feeding, or defecation. The mechanism involves increased right-to-left shunting due to a sudden decrease in systemic vascular resistance or spasm of the right ventricular outflow tract. Exam Pearl. A squatting child who becomes less cyanotic is a classic exam scenario. Squatting increases systemic vascular resistance, which reduces right-to-left shunting across the VSD and forces more blood through the pulmonary circulation. On examination, you may hear an ejection systolic murmur in the pulmonary area due to the right ventricular outflow tract obstruction. Paradoxically, the murmur may become quieter during TET spells because less blood is flowing through the obstructed outflow tract. Patients may develop clubbing due to chronic hypoxemia. Chest X-ray shows the classic boot-shaped heart or cur en sabot caused by right ventricular hypertrophy and a concavity where the pulmonary artery should be. Echocardiography is the definitive diagnostic investigation, demonstrating all 4 components. It is also used to assess severity and plan surgical management. ECG may show right axis deviation and right ventricular hypertrophy. Management of a TET spell in the acute setting. Bring the child's knees to the chest to increase systemic vascular resistance. Give high-flow oxygen. Administer IV morphine for sedation. Give IV fluids for volume expansion. If refractory, phenylephrine and alpha agonist can be given to increase systemic vascular resistance. IV beta blockers, such as propranolol, may help relax the right ventricular outflow tract. Definitive treatment is surgical. Complete surgical repair is ideally performed between 3 and 6 months of age. The repair involves closing the VSD with a patch and relieving the right ventricular outflow tract obstruction. In severely cyanotic neonates who are too unwell for early complete repair, a modified Blalock-Taussig shunt, a synthetic tube connecting the subclavian artery to the pulmonary artery, can be performed as a palliative bridge to increase pulmonary blood flow. Prostaglandin E1 alprostadil may be given to keep the ductus arteriosus open in neonates who are duct dependent, maintaining pulmonary blood flow until surgery. Rapid-fire summary. Most common cyanotic congenital heart defect, Tetralogy of Fallot, 4 components: VSD, RVOTO, overriding aorta, RV hypertrophy. Severity determined by degree of right ventricular outflow tract obstruction. TET spells, acute cyanotic episodes, treat with knees to chest, oxygen, morphine. Squatting increases SVR, reduces right to left shunting. Chest X-ray, boot-shaped heart cur en sabot. Definitive diagnosis, echocardiography. Definitive treatment, complete surgical repair at 3 to 6 months. Palliative bridge, modified Blalock-Taussig shunt. Neonatal duct dependence, prostaglandin E1 to maintain ductus arteriosus. Murmur, ejection systolic in the pulmonary area, quieter during TET spells. That's your complete review of Tetralogy of Fallot. Study smart, not hard. If you found this episode useful, subscribe, leave a review, and share it with your study group. This has been Quick Medical Review. See you in the next episode.